help a loved one with their everyday. Parkinson's disease is a progressive neurodegenerative disorder that is characterized by motor and non-motor symptoms. It is seen as a depletion of dopamine-producing neurons in the substantia nigra. Researchers believe that other parts of the brain are included, but this is the main area of the brain that they see, that depletion of dopamine. There is no cure because it is a progressive and a degenerative disease. There are treatments, however, that have been shown to help alleviate symptoms, and Parkinson's disease is recognized by the presenting symptoms. There are four cardinal motor symptoms that really present as Parkinson's, and that is the tremor. Tremor is the unintentional continuous movement of a body part. So if you see an elderly person, with the continuous movement of their hand, or sometimes you can see it in their head, that's a tremor. Muscle rigidity is a stiffness to the body or the limbs. That's just kind of when their muscles aren't really allowing them to move much more than kind of like a robot. Bradykinesia or akinesia is the slowness of movement or the complete lack of movement, and that can be throughout the whole body. Postural instability can be seen when individuals have impaired balance and coordination when they walk or when they stand. These symptoms, along with the others that are part of Parkinson's, appear in different stages and at different levels of severity and can progress as the disease progresses. There are also non-motor symptoms of Parkinson's disease. These include the disturbances of cognition, sensation, and perception, mood changes, the lessening of motivation, changes to behavioral inhibition, sleep disturbances, and the comorbidity with other diagnosable conditions such as dementia, depression, anxiety, and other forms of psychosis. These symptoms are prevalent and as seen by many of the patients who suffer, and they suffer from more than one of these non-motor symptoms. Patients often state that non-motor symptoms are more detrimental to their quality of life than our motor symptoms because they are experienced as causing more disability and distress on themselves and their family members compared to the physical features of the disease. And again, these symptoms can appear at different stages of the disease and at different levels of severity. One set of researchers that I found focused particularly on pain. Not all patients with Parkinson's disease will experience pain or at the level of severity that others will, but these are the types of pain that they identified. Musculoskeletal pain is a type of nociceptive pain that is enduring and intensified by force, physical activity, and exercise. So it's a kind of a muscle pain that's always there, and then if you were to move or do any physical activity, that would really start to aggravate that pain in your muscles. Dystonic pain is caused by dystonia, or the uncontrollable contraction of one's muscles that progresses into a repetitive pattern of spasms. So dystonia is the spasms of the muscles, and when it becomes so continued and uncontrollable, that's when it starts to become really painful. It is considered the most painful symptom that Parkinson's disease patients experience, and it is also considered to be one of the presenting symptoms of Parkinson's disease, especially when involving the feet, and that includes the gait. Gait is one of the things that patients with Parkinson's disease really have trouble with, is just their step and their continuous movement in their feet. Akathisia is described as subjective inner restlessness, producing an intolerance of remaining still or a painful impulse to move continuously. And so even though some symptoms are the inability to move, this is a symptom that really the person just really wants to move, and they really feel that they need to have this urge to move, and because of that, it's really painful. Those three symptoms of pain are known as nociceptive pain, and that's just somatic. That's more surface or muscular. The next two are the neuropathic pains, and those are more at the nerves. Radicular neuropathic pain is continued pain, numbness, or weakness that is felt at a specific nerve location, whereas central neuropathic pain is localized nerve pain like the other one, but it presents as a quick shooting pain. Like I said, there are treatments for Parkinson's disease. The most standard treatment for almost all patients is dopaminergic medication, such as levodopa or L-dopa, and what it does is that it replenishes the dopamine levels in the brain. And this has been shown to markedly improve the physical symptoms, so all the motor symptoms that we just talked about, but unfortunately has not been successful in relieving non-motor symptoms. L-dopa has also been shown to improve the apathy scores of patients with Parkinson's disease. Brain stimulation is another treatment. It's another option for patients with Parkinson's. And the brain stimulation happens in the subthalamic nucleus. And it is really beneficial for people who are drug resistant to the levodopa. And what that means is that their body's just not wanting to produce dopamine, and it's being resistant to the drug trying to help it do so. And so the deep brain stimulation helps with the motor symptoms, but there have been reports of increased apathy and increased emotional disturbances. Quality of life is definitely affected in the everyday life of a patient with Parkinson's disease. They have a loss of ability to do everyday tasks on their own as their disease progresses. There is a high chance of occurrence of depression, and with that comes the presentation of apathy. There is also a social impact on patients with Parkinson's and caregiver burden. Quality of life can be seen as, for a patient with Parkinson's disease, as the deterioration of their cognitive domains, which include attention and executive function, social cognition, emotion recognition, and learning and memory. And so if there's deterioration in all of these aspects of somebody's life, I can really understand how that would be detrimental to the quality, unfortunately. Depression is one of the more prevalent diagnoses that is, comorbid with Parkinson's disease. Researchers have found that it is exogenous and endogenous, meaning that it could have originated outside of the organism. So based on, just knowing that you've now been diagnosed with this progressive degenerative disease, that could really make somebody upset. That could really lead to a depressive state, and that would be something, affecting those symptoms from the outside. but has also been shown to be endogenous, which means that it's originating from within the organism, and so that's where researchers think that it is more related to Parkinson's and how all the non-motor symptoms and the motor symptoms affect an individual. Depression in Parkinson's disease leads to more rapid physical and cognitive deterioration. And there is it does restrict the ability to perform activities of daily living. It says right here that depression tends to be more prevalent shortly after diagnosis and at the end of the disease progression, and this suggests that depression is due to a combination of the subjective reaction to receiving the diagnosis and the underlying brain dysfunctions caused by the disease when it progresses to later stages. So that again is just kind of showing where the depression comes from within Parkinson's disease. And associated with depression is apathy, and it is also associated with cognitive decline, disease progression, disease severity. And apathy is just this lack of wanting to do anything. No positive moods, and it's just this not wanting to see the positives in things. The social impact of Parkinson's disease was actually explained really well in an article by Hemish. And what she did is she did research on patients with Parkinson's who had facial masking, and that is the facial movements become slower, less fluid, and more effortful, and vocal and bodily expressions of emotion and social engagement are reduced and become less spontaneous. And so you can really start to see that masking on somebody's face. And there's also abnormal body movements, and those are just some of the other motor symptoms that we've seen. And what this researcher did is that she had videos of individuals with Parkinson's disease, and what she did is that she had older adults view these individuals and have them come up with first impressions, and the crowd was a little tough, and they thought that people with Parkinson's disease did present as less socially positive, acknowledging that facial and bodily cues do have social implications for older adults. She found that facial masking has been found to be more detrimental to impressions of the social supportiveness of women with Parkinson's disease than men, whereas normal body movement may be more harmful for observers' impressions of men with Parkinson's disease than women because physical ability is more closely associated with male gender. So this study on the first impressions of older adults with Parkinson's disease is really telling of how we're seen by others, and this is just kind of another pile on to what patients with Parkinson's already have to deal with. So just, I guess, be wary that we have impacts, on the people around us, and if we're going to be judging somebody based on something they can't control, that doesn't seem fair, does it? So it was a really well done article that really opened your eyes to that, stigmatization that some people face because of, diseases and disorders that they have. And there's not just burden on the patients, there is caregiver burden. And there was a study that caregivers assist 11 times per day in the early stages of Parkinson's, and that's with, activities of daily living. And then in later stages, they can assist their loved one up to 30 times a day. And this article by Dobkin et al. Says the inclusion of family members in psychosocial interventions for chronic medical conditions has been linked with improved patient outcomes across a range of physical illnesses versus usual care. And so while that sounds positive, it still takes a toll on the caregiver and what they have to do. Bogert 2011 says researchers have noted that patients with apathy are not distressed or bothered by apathy, but it is significantly distressing to caregivers. So the people who are caring for their loved ones and see that they don't care, or maybe not don't care, but that their motivation and their positivity has been drained, you could see how that would start to take its toll. There was an article by Masters, McCone, and Paul, 2004, that talked about implicit motor learning for Parkinson's disease. And they started with the disturbed movement execution, which occurs when the parameters of the movement are explicitly known in advance, which means when the movement is pre-programmed and the results from a malfunction in the descending motor commands that control the mechanisms of the movement. So essentially, somebody knows how to do a task, but since they've now put the rules behind it, they know what they're supposed to do, it's almost like their brain is overthinking it and allowing them not to do the movement. It's kind of like when an athlete really overthinks what he's doing and they get the yips. It's just this inability to execute the movement that you're trying. And so what they've come up with is this implicit learning idea, I guess, that essentially people learn to do the task without really thinking it. And so there's no qualification to what they have to do. There's no rules set. And this is kind of done through errorless learning, and they actually gave a really awesome example that your loved one with Parkinson's disease can rehabilitate their movement to pick up a cup. And it's errorless because at first the cup is going to be large. It's going to have a good handle, and it's going to be a big cup so that they can slowly move and grab it. And as they go and as they're practicing, the cup will get smaller, and they will not have to think about it as much because there's no error. The cup is designed in a way that they're not going to drop it. And so it's easily grasped, and it permits few errors. And so, like I said, the size will decrease over time to more normal proportions. But because that was learned in a way that it was automatic for the person, it was stored and easily retrieved implicitly. So again, that's plainly expressed without qualifications. So it's an implicitly learned knowledge which results in the implicit functions bypassing working memory. So they really don't have to think about it. They've not had to do trial and error, which means they don't really have to focus on the error. They just get to focus on the fact that they very easily grabbed the cup and can continue to move on and move forward with that. So if you could see, this could be a really awesome rehabilitation method for somebody to do with maybe an occupational therapist or even with their family members, relearning, rehabilitating some of the movements that they have lost. also an article that talked about cognitive behavioral therapy for depression. And this article was by Dobkin et al., 2012, and it took the individual with Parkinson's and their caregiver, and they found out that having a spouse involved in the treatment was more beneficial than any other family member or friend. That totally makes sense in my mind. But what they did is that for 10 weeks, they met once a week. So for 10 weeks, the caregiver and the patient with Parkinson's with depression went to learn CBT, and together they worked through some of the factors that are included in Parkinson's disease, and the patient was on their medication, and they were able to provide initial support they were able to lessen the acuity of the symptoms of depression. And so their hypothesis was that a family member would, a caregiver would be able to help them more easily and more successfully get through the CBT and have it make a change. And there was a positive change in the symptoms of depression. And the findings from this study provide initial support for supplementing individually administered CBT with a standardized caregiver as well as with the patient with Parkinson's disease. And so again, this is just another great opportunity for the family to get involved and help their loved one through the process of Parkinson's disease, be able to better cope with the symptoms that they have.